All righty. Dr. Hopkins, thank you very much for a very stimulating, probably some would say slightly controversial presentation this morning. So you trained as a classic neurosurgeon.
I did.
So how did you learn catheter and wire skills?
So I got to a point in my training where I had the opportunity to learn how to do diagnostic angiograms, and it was percutaneous carotid injections. And I thought, there's got to be a way to better access the vascular system. Then along came the Seldinger technique, and so I just got thinking, there's got to be a better way to treat some of these vascular problems other than just, opening the hood and lifting the engine, which has significant morbidity. And then the very first case that I remember that was an epiphany for me was a simple carotid cavernous fistula. Somebody came in with his eye all red and inflamed and protruding. And back then the treatment was to cut down on the leg, excise some muscle, and then cut down on the carotid artery and let muscle pieces go up and try to plug the fistula. And I just thought, this is pretty crude. And so about that time there was a balloon that had been developed. It was a triple lumen balloon developed by Prolo in Boston. And so what we did is we cut down on the carotid artery, and we took that triple lumen balloon and we navigated it up. And we could inject dye and we could see what was going on, and we got it up to the fistula, and we were able to shut the fistula down by occluding the artery. And the patient did very well. What was interesting is I had this long catheter. I had to do something with it, so I rolled it up and I buried it under the skin, closed it up. And then the patient did well. Fistula was cured, but a couple months later the patient was like, I can't deal with this anymore. So I went back in and I cut the catheter off. Meanwhile, I put a bunch of wet clips on the catheter and cut it off. And that was my first real endovascular case. And then we started embolizing AV malformations, and there were a couple of radiologists who were really into it, people like Grant Hiroshima and Chuck Kerber. And I went out and visited these guys and learned what I could from them. And then we started doing things. And that's how I got into it. And then as the thing evolved, and then catheters got better and better to the point where we'd actually navigate up into the head and we could really start to do things. And that was back I started out in the mid-70s, early to mid-70s, and then by the mid-80s, I took my first fellow. And then I've been training fellows ever since.
So for a neurosurgeon to do intracranial intravascular interventions, is that now part of training neurosurgery, or is that an additional cerebrovascular fellowship beyond that?
Great question. And now the way neurosurgery is structured, it's possible to do an in-training fellowship for at least 1 year. And most of the trainees today will do a 1-year fellowship during their training. And then when they're finished their training, they'll go do a full year of endovascular neuro. And that's how our fellowship keeps going every year.
So one of the things we do a lot of is cone beam CT, 3D imaging. We learned it all from the neurointerventionalists. It was really part of their workflow. It was an example of a silo, as you talk about. They were doing this, nobody else was doing it.
Right.
We had the capability, we had the technical capability, but we never really integrated that in our workflow, and now it is. And so I'm fascinated by what you're trying to do, and we call it the other guy's toolkit. What can I learn from other people? I always say that I learn more from working with non-vascular surgeons now than I do with working with vascular surgeons. I can always learn from anybody, but I love working with the neurointerventionalists because they have skills that I don't have, and they have technology that I don't have, and we like to learn.
We feel the same way about you. So the more we hang out with cardiologists and vascular surgeons, the more we learn that we can apply to what we're doing up here. And the epiphany for me was our Neuro Complications Conference, which started 30 years ago. And then we thought, why don't we bring all the disciplines together and bring the thought leaders from all the major disciplines and that first year was an extraordinary learning experience for me. And that made me realize that you guys know about things that we need to know about. And that's been the exciting thing that's come out of that conference ever since. And the more we can integrate the disciplines, the better it is. So I think it's very hard structurally in most institutions because of the fact that every department lives in a different area of the hospital. But finding ways to break down those barriers and bringing these guys all together is what I think the future may be all about. Particularly when you think about where healthcare is going in terms of the pressures on cost and outcomes and all that stuff. The more we can learn from each other, I'm sure we can find ways to save money if we're all working together. For example, somebody comes in with problem X that's a cardiac problem. And by the way, he's also got a couple of other problems that may relate to other vascular systems. You get it all done in one shot. And all we have to do is be there in the same space working together. And it's easy to, instead of having an extra cup of coffee, just to go in and help somebody from another discipline fix a problem that was unanticipated, discovered at the time of the procedure. And that's exciting. Patient has an acute stroke during a cardiac intervention now. They don't even leave their table. They just call us. We just go over and take care of it right where it is. So it's a really incredibly synergistic environment that I think is going to benefit everybody down the road.
So you talked a little bit about the interventional suite structure in the JI, and you mentioned about there are vascular operating rooms that are convertible into cath labs or have actual imaging systems built into them all at the moment.
Yep, we've got plans. We've already got one of the ZIGO systems in one of the ORs, and we've got it in the budget to put another one. Actually, we've decided to go with another design. That ZIGO is it's so huge. It's a great system, but it's so huge. But all the cath labs were designed to be convertible. And so all the structure, all they got to do is put the racks in, and the equipment will follow, and we will convert them. Will that happen? I don't know, but we think so.
So I'll make a statement I think you'll agree with it, in that if you're working on the cardiovascular system, it makes no sense to me that if you're working to do an open operation, that you don't have the capability to switch backwards and forwards to an endovascular, because you never know when you're going to need that. And yet the way that we've traditionally built operating rooms is you have an open operating room. You're lucky if you can pull in a portable C-arm because we got all the metal on the table.
That's right.
And it fundamentally hasn't made any sense to me that that's the way we're working.
Absolutely, and that's the beauty of the surgical disciplines doing the endovascular, because as you well know, if all you have is a hammer, the whole world looks like a nail. And before we had interventional capabilities, we didn't know any other way. And I can give you one wonderful example in our case. A patient with a large carotid ophthalmic aneurysm right at the point where the carotid artery enters the head. We know that we're going to never get good proximal control. So we just put a catheter here, and we can, when we're ready to deal with the aneurysm, we can basically shut down the flow in the carotid artery and then take the pressure out and lower the risk. And then if the clip doesn't completely occlude the aneurysm, just take a catheter up and fill it up with coils. So we've combined the two disciplines, and I think more and more we're seeing that to be able to go back and forth is huge. It's life-saving. And it's probably saving an awful lot of time and money as well. Rather than, well, I tried to deal with this thing with surgery and it didn't work, and I'm going to send it to the catheter guy, or vice versa. That doesn't make any sense. You need to be able to do it all. And if you can't do it all yourself, you need to be in a team that can do both, so that, hey, I got a problem here that I really need you to put a catheter in and fix this. And I think that's where I think we're headed.
No, I totally agree with you. it's hard being on the front end of this without getting a lot of pushback, both from your own specialty and from others. What kind of pushback have you had in the neurosurgery world?
I'm a pariah. In the neurointerventional community, I'm a pariah for suggesting that cardiology should be involved. There are hurdles to getting cardiology involved. And the question that was raised today, they're right that you need to make sure that somebody starts monkeying around in the brain, that they have a pretty good idea of what they're doing. So they need to be trained. But what bothers me is seeing training standards developed by neuro that are really designed, at least in part, to block other specialties from getting in. That doesn't make any sense. So working together with everybody, getting people, and the amazing thing about working side by side with all the other disciplines every day is that the more you work together, the less the disagreements. You're there, you're communicating, and it works. I mean, the barriers, most of the barriers, I think the barriers we've had with the university have been all about communication. Yes, there's a desire on the part of the university to control, because that's what they do. They control most everything, and they would like to control. But there are things they just can't do as well. But the important thing is communicating. Here's why we want to do this, and we can do it better and faster than you can, and we'll give you credit for it. And I think if we can just get that mindset going, we're going to be in good shape with the university, with the hospital, with everybody.
I think this concept that you raised of when industry has a device to be tested, the longer it takes to get through the clinical trial, it costs huge amounts of money. And so not only is it good for industry, but in your center, if you can expedite the IRB process, the budgeting process, that is a strategic advantage for your center.
Huge. Clinical trials. Universities are really not that good at running industry-sponsored trials. They're great with government-sponsored research, but with industry-sponsored trials, you need to be hand in hand with the university. You need to be an expert at site management when you're doing clinical trials. Gosh, I'm sure you remember many of the carotid trials where there were guys who were entering patients that never should have been entered in a carotid trial because I'm in the trial and I want to do this case. And so I'm going to enter this patient in the trial. That patient should be having a carotid stent. Should be having something else. So we got to manage sites and I think I call it management of the university and the university relationship. It's proving to them that we're there for them, but it's keeping our distance when we can do a better job than they can and still give them credit for it. It's managing other physicians, who they aren't realizing that the reason that this device is in a clinical trial is to get it to the marketplace. First to find out if it works, but it's to get it to the marketplace. That's what it's all about. Once you get it to the marketplace, then all of us can decide when and where we use it, right? There's all this business today about on-label, off-label, and we've been working with the FDA, and it's clear they I think, are beginning to understand that they approve a device for a specific indication, but it's left up to us to decide when is it the best time to use that for a given patient. So it's all about communication. The whole world is, if we could just communicate better, we'd be in better shape.
Amen. Thank you very much indeed. We really appreciate you coming down here. Thanks a lot.
Thank you.
Bye.